Okay. Next, communication scenario is what we call conspiracy of silence. Okay, what is conspiracy of silence? Conspiracy here means cooperation, illegal cooperation. Silence means keep quiet. Okay, so how could this happen in medical? Actually, in fact, it's quite common. Okay, I will let you see the scenario and then we discuss. Okay, no video for this session. Okay, so for doctor, in all the exam or ending, you will have a stamp of a scenario for doctor and also for patient, the surrogate. Okay, so are you all with me now? All of you are here. Okay, so for doctor, Mr. A, you look at the slide. A 64-year-old man came to see you a week ago for loss of weight for a month with jaundice. He's due to see you tomorrow, but his wife has called to see you today. You are reviewing Mr. A's ultrasound and blood test result. It shows that he has a 6 cm mass in the liver with metastasis. Okay, so this is for doctor. And for the wife, now you are dealing with the wife, not the patient, the wife. Okay, the wife, for wife, Mr. A, your husband, 64-year-old man, saw the doctor a week ago for loss of weight a month with jaundice. You went with your husband to have ultrasound done at hospital yesterday. You asked the personnel doing the ultrasound about the finding, and they told you there's something from the ultrasound and asked you to see the doctor. Your husband is due to see the doctor tomorrow, but you have decided to call the doctor and ask to see the doctor today. You want to know if it is cancer and how bad the cancer is. You will not want your husband to know the diagnosis, as he is someone who is pessimistic and not fight the cancer. Okay? Roughly, you know the scenario, right? Okay? Let's say you were the doctor. The patient come to you, say, doctor, my husband, yesterday I accompanied my husband for ultrasound, and the personnel there told me my husband may have something. I wonder whether it's cancer. Okay, doctor, can you tell me whether, and if it's cancer, don't tell my husband because he's quite pessimistic. He may give up treatment and he may get depressed. Okay, so how are you going to deal with the wife? Anyone? You understand the scenario, right? So now the wife is in your clinic. Anyone try your best. It's okay to make mistake. It's okay. I would say this is quite a difficult scenario, right? Yes, Kumuta. So yeah, your confidentiality, yes. So should review with husband. Okay. Okay. Now, Kumuta, to ease her anxiety first. So what are the anxiety here? You want to say something, Kumuta?
Hi, Prof. So
Uh,
I think she's worried if the husband is having cancer. She want to know the diagnosis if it's a cancer. So that's
mm,
and then the husband is a pessimistic personality. So she's worried the husband may not take the news very well. So, since this is her concern, but the diagnosis I don't think we can reveal because it is patient confidentiality issue. So what we can do is, if she insists she want to see the doctor, we can meet her and then we can try to understand what is going on with the wife. Maybe there is some form of caretaking burden involved, because weight loss 1 month and jaundice, I'm sure the symptom is not just for a month, maybe already few months, but it's just that now that the metastasis has occurred, then they are worried and then they seek for intervention.
Okay, good. So from here, you actually know the ideal concern and expectation of the wife already, right? So can you try roughly tell us what are the ideal concern and expectation here?
Okay, so the idea is the wife, I think she most likely knows it may be cancer because the ultrasound personnel also told her something is wrong. So
Yes.
so the idea is maybe she thinks it's a cancer. The concern is she's worried how bad the metastasis is, the stage of the cancer, I think. Then the expectation, she expects the doctor not to tell the result to the husband.
Okay. Also, the concern is that husband might give up treatment also, right?
Yes, Prof.
And another expectation is that she expect the doctor to tell her the diagnosis, right?
Yes.
Okay, good. Okay, Renu, you mentioned here, advise the wife to come with the husband to inform the result, right?
Mm. Yes, Prof.
Okay.
So
Uh,
actually, we can see the wife if on that day only wife only came,
mm,
but the actual diagnosis should be done together, maybe together with the patient and the wife. If the wife is
okay,
to be
now one more question. If the patient come with the wife together tomorrow lah, so you want to tell both of them together the diagnosis, or you want to tell the husband only?
then we will first usually we'll have to see the patient first.
Mm,
So then maybe before breaking the news, we can ask, would you like to have the wife next to you before knowing the result? Because maybe the patient was there during the scare. The doctor already mentioned there's something. So maybe he also has a vague idea
yeah,
of the
okay,
result being positive of something.
okay. So in other words, you still need to assess the condition first, right?
Yes, patient's willingness for the wife to be
Yeah,
next to him.
yeah, okay, good. So go back to the basic, okay? So I mentioned just now, whenever I have a difficult situation, so you always need to assess the patient before you counsel. Assess the wife before you give any counseling. Okay? And this case is quite complicated. So I myself think that if you want to handle this case, you must ask yourself two questions first. Okay? First question is, are you going to tell Mrs. A the diagnosis before patient? Second, would you withhold the diagnosis from the patient? So you'll try to answer. These two questions will decide you whether you are on the right track ethically or you're on the wrong track. So anyone, for the first question, are we going to tell Mrs. A the diagnosis first?
No,
No. No. Anybody else? So far, I can only hear from, okay, Katini. How about the rest of you? Okay, so we have more. Okay, now I ask Joshua. Okay, why you say no? Now we are still in the first question, are you going to tell Mrs. A the diagnosis? Say no. Why? Joshua, are you around? Hi, Joshua. Are you around? No response. Or have you had any problem with your mic? Okay, it's all right. Aisha?
Yes, doctor.
Yeah, okay. You say you don't want to tell the wife first. Why?
Because the patient had the autonomy and also the confidentiality lah. So we should actually ask the patient first, does he want first before include the wife inside?
Okay. So in other words, the ethical principle here.
Yes.
So what are the ethical principle here?
Oh, the autonomy and also the confidentiality.
Yeah. So you shouldn't tell lah. Okay. Now the
Yes.
second is
The diagnosis, I think I will tell the patient first lah, provided that he is ready for the diagnosis.
okay. So in other words, will you collude with the patient's wife, or will you cooperate with the wife not to tell the patient?
No,
Why?
because it's not ethical to withhold diagnosis from the patient himself.
The issue?
The autonomy and also
Yeah, same thing.
confidentiality. Yeah.
You still need to keep the autonomy for the patient, right? Also justice, yes. Also justice. Also beneficent. There's so many technical involved. Okay. Now, okay, you're on the right direction. Okay, Aisha, thanks.
Okay, doctor.
Now another question. Then how are you going to deal with the wife? Wife already in your clinic. You have the principal already in your mind. How are you going to deal with her? Okay, Kumuta again. Anybody else lah? Don't always ask Kumuta to answer.
Hi, Dr. Hao.
Hi.
I'm Edwina here. Yeah.
Hi.
I think with the wife, you have to explain about the principle of autonomy in layman terms,
Yes, very
and
good.
explain to the wife that we cannot disclose to her the result of the husband, even though she's the wife.
Yes, that's one way. Any other
Yeah.
more convincing points? This is one way. Yes, you tell her about your ethical position. So any other way? But the wife may not know, right? That's why the wife may not know about all this. You should tell her first. This is one way lah. As doctor, we shouldn't tell you the diagnosis first. We must tell the patient first. And it apply to all the patient, okay? Not only your husband. We apply this principle to all the patients. Okay, Roslyn, yes. Where's your wife's concern? Okay, can you elaborate more?
I would on during the first visit, if the wife asks if the wife wants to know the diagnosis first before the husband, I would first acknowledge that the wives have the right to be concerned about the diagnosis, but at the same time, diagnosis should be reviewed together with the patients because it's the patient's right.
Yeah, good. But if the patient, let's say the patient's wife say, I'm so worried about the pessimistic of the patient. He might want to give up the treatment. Her
Or
idea is and expectation is the doctor don't tell him. So how are you going to explain to her? you need to tell the patient also?
We need to explore more about how pessimist that husband can be, and also we also can offer a supportive approach in order for the patient to go through the diagnosis and the treatment for the disease. So
Okay, that's good. So what kind of supportive measurement you want to take?
we can refer the patient to the oncologist or the specialist for the particular cancer and see the treatment plan for the disease.
But if she say, my husband if know about this, he won't come again to clinic or hospital again. How?
Refer for counseling or other
He don't even want to come, how to refer for counseling?
um other supportive measures. We can refer the patient to hospice. They can
If you say about hospice, meaning that patient has cancer already lah.
yes.
But you already explore, inform the patient.
Okay. I'm not sure about that.
Okay. So anybody? How to deal with her? Because she keep on want you to keep the secret from the patient. So how you explain to her or convince her we need to tell the patient the diagnosis? Any reason for that?
Can I try, doctor?
Yes, sure.
So first with the wife, we need to tell, even if we let the wife know the diagnosis, the further treatment and plan will require Mr. A to be at the clinic or go to the hospital. So somehow we have to get Mr. A to be in the clinic for him to receive the diagnosis news and all. So, and
Yes,
he
you
will be
are on the
anxious
right track.
also. So regardless if we don't tell him, then we cannot move forward with the treatment or anything else.
Yes, that's one point. So can you rephrase your sentence? Yes, you are in the right point.
First will be patient anxiety. He is in the
Yeah.
dark. Second one is patient. Patients need to know of the
Yes.
diagnosis of his health.
Why he need to know?
Again, back to the same thing, autonomy, his body autonomy. He is mentally and physically sound to receive the diagnosis.
Okay, that's one point. Okay. Yeah, good. I try to rephrase for you. Okay. What you say is correct. Patient, it's very difficult for the patient to undergo further investigation or treatment without knowing what happened to him, without knowing the diagnosis, right? So it will create a lot of anxiety and stress, like Reno mentioned. And because the patient is pessimistic, so all this stress and anxiety, he may not able to stand it. So he may get depressed also if he didn't know about what happened to him. Okay, that's one point you need to explain to the wife. We should tell the patient the diagnosis. So any other point? So you already get on the right direction. So you must explain to the wife. Now we are now in a stage that we don't want the conspiracy of silence to happen. So any other reason for that? We don't want conspiracy of silence. Yes, to create trust. Nurul Huda, you are on the right track again. So elaborate more. Nurul?
Yes, doctor.
Yes.
I try. For my opinion, if we keep a secret to the patient, doctor-patient relationship might be what do I can say? It's wrong to keep a secret, lah, doctor. And then patient will not trust the doctor and difficult for doctor to plan further treatment to the patients.
Okay, so whatever you say is right. But patient, if don't know,
Sorry, doctor.
they don't know, they'll trust you what?
Somehow later, maybe the when the patient find out one day, he
Yes.
will not trust me anymore.
Yes, exactly. So it's very difficult to maintain a secret from the healthcare provider and the family also. Somehow the truth may surface one day. So you must let the wife know. If the truth surface one day, the patient will even more upset and lost confidence and lost trust to doctors and family. And at point, patient will give up everything, even worse. Yes, correct.
Yes, doctor.
And it's one more point. Anything else you can convince the wife? You don't want conspiracy of silence. One more thing? Anything else? Anybody else? Because right, but if you find all these points, you tell the wife, then the wife may accept it lah. Okay, it's all right. I think we are a bit behind the schedule. One more thing is can tell the wife that if the patient have terminal illness and he didn't didn't talk about the diagnosis, he wasn't told about the diagnosis, and he might not have chance to do whatever he want to do. Yes, Will's bucket list at the end of hours of life. If he knew his time was short, he might want to write a views, like Nurul does say, bucket list to do, lot. Want to wish, go to place you've never been before, want to say sorry to someone. Okay, and if that happen, he will be kind of being isolated from the family, right? From the family and doctor, and he become lonely. And if that happen, it will contribute to the stress and depression also, right? Okay. And one more thing is that the worst scenario, worst case scenario is patient already know about what happened to him. Because the family want to keep a secret from him, he's forced in a conspiracy of silence. Okay. Silently participate. Okay. And by pretending he didn't know about diagnosis. That is worse. Okay. He will be very lonely and what we call isolated death later. And if that happen, later the bereavement for the family will be complicated. They may feel guilt after that. So you can let the patient's wife know about this. Okay? And it's cover most of it. Okay, let's go through the slides quickly. So the information must be discussed with patient first, like what we say. Okay, if you must be firm and approachable throughout the process. Okay, and showing the patient's wife the ethical position is helpful. Okay, explain the difficulty by not knowing the diagnosis. Okay. Okay, you can also tell them it's quite a natural response, become upset, and many patients can adjust to the bad news. Okay. And of course, you need to see the patient first. Like one of you mentioned just now, if patient don't want to know, you meet him tomorrow. He show decision that he don't want to know the bad news. He want the wife to know. Then you can tell the wife only at that point. Okay. If collusion happen, conspiracy happen, then we must challenge it lah. Okay. This is what I mentioned, isolated death, not knowing the diagnosis, and very stressful to maintain the secret. The secret may surface, the truth may surface. Okay, need to challenge the collusion. Okay, that's all. Any question? Before we go to palliative. Okay, quite complicated lah. We just get to know this. Usually it won't happen in exam, this kind of scenario. Okay. Now, before we go into palliative session, I have a video for you. This is a video created by Hospice Malaysia. Okay, and because a survey done by Hospice Malaysia show that there's an alarming rate that 90% of the population, including healthcare providers, didn't know about palliative care service. 90%, quite alarming. That's why I create this video to create awareness about this. You can watch the video, just relax, no question for that. And maybe the beginning part is a bit against what we teach just now. I teach you just now. But you try to watch the video lah. That's for the meaning. They try to tell you something on the video. Okay, you just watch lah. Then no discussion for that. Just for you to watch and be alert about the alarming rate of palliative care service. People don't know about palliative care service.
But the cancer cell got aggressive and it spread to the lymph nodes, and it is at stage 4 now.
Ini mesti serius.
Mak, kita tak boleh bagi tahu Abah. Nanti dia putus asa.
Kalau perkara ini serius, saya kena tahu. Kalau tak boleh sembuh, saya kena bersedia, Nora. Saya tak nak buang masa keluar masuk hospital. Banyak benda saya kena buat.
Puan Nora, saya tahu apa yang awak risaukan ni. Tapi dari apa yang saya tahu tentang Cik Yusof, dia mesti nak tahu apa yang sedang berlaku.
Papa seorang ke hospital. Saya langsung tak ada masa untuk dia.
Mak. Anita. Baba kamu tu seorang tabang. Tapi kalau dia tahu, dia mesti risau tentang kita. Macam mana Mama nak jaga ni?
Apalah Nora akan buat bila saya dah tak ada.
Kalau pesakit dah tahu masa dia dah suntuk, dia mesti nak luangkan semua masa yang ada dengan orang tersayang. Macam ni, biar saya tolong awak sampaikan berita ni dekat dia.
Kalau macam ni, tak dapat makan nasi lemak lah jawabnya.
Nak makan apa-apa pun boleh. Kita akan jaga simptom Cik Yusof.
Terima kasih, doktor. Saya akan rasa sakit tak?
Yang itu, kita boleh jaga.
Kita balik rumah lah, Nora. Saya nak balik rumah. Okey. Okey. Yang klik file. Lepas tu klik print.
Okey, cuba ah.
Okey. Silakan cuba.
Lepas tu
Klik print.
print. Tak ada pun.
Lah sayang, awak ni macam-macam lah. Risau bang bila saya dah tak ada. Sayang, saya masih kat sini.
Abang, jangan cakap macam tu.
Okay. 1 minute for emotional ventilation. Okay, it's very touching, right? This video. Okay, the beginning part is maybe a bit different from what we learned just now. But I think the purpose of the video is just try to illustrate how does the patient feel, right? Actually, Encik Yusuf actually want to know about what happened to him, right? Yes, actually patient want to know. So family may think that nanti apa putus asa, whatever, but the patient actually want to know. And in this video, Encik Yusuf actually got a chance to spend with the family. Okay, the quality of life is there at the end. Unlike the father of the mother, right? Encik Yusuf's wife is spent in the hospital alone. So it's not what we want. Okay, that's all they want to tell you. You can share this video to your friend to create awareness about palliative. Okay. Now, can we proceed? Okay. In palliative sessions, we'll discuss about pain relief. Okay. If you be alert, just now in the video, actually the nurse showed about the morphine, syrup morphine. Okay, later we'll discuss about that. And emergency and terminal care. So already discussed during the tutorial session, if you still remember. And group discussion on resource. That's about the service of palliative in Malaysia. Now we go to the next case. Case number 5. NG, 55 years of age, was diagnosed with stage 4 breast cancer with mets to L2 to 4. She had radiotherapy to the painful bone, mets with good result and chemotherapy. She now presents with pain in the lumbar spine. Okay, what scale can you use to measure pain? I mean, here it's not only adult, even pediatric, you can let us know. Kumunda, what is visual analog, okay. Melati, okay. Melati, Wong Baker, is your mic okay? Wong Baker is what? You just type Wong Baker is does it look like? Yes, face reaction, okay. It's used in adult or pediatric case. Yes, pediatric, 3 to 7 year old lah. Okay. So these are the pen scale we can use. Visual analog is one of it lah. Or numerical number, numerical. And this is graphic scale is Wong and Becker. Okay. And this scale is what we call self-reporting scale. And if the patient is younger than 3-year-old or patient who are unconscious, we use observational scale. For instance, it's a FLACC. Okay, you can Google it. Okay. Now you know that pen is fifth vital sign. Right? Pen score is fifth vital sign. Right? Okay, why you want to have pen score? Why you want to scale the pain? Anyone? Management changes. Okay, can you elaborate more? Okay lah, continue for progression. Continue progression. Then how do you assess
Hi,
it?
doctor. To see that
Exactly.
whether the treatment we give, is it working? Is her pain progressively improving or not?
Yeah, then meaning you assess the pain score
Assess the pain score.
before and after the treatment. Okay.
Yes, doctor.
Okay. There's another way to another reason we want to use pain scale is when we do the research now, when you want to objectively measure the pain. Okay. Okay. Now the next question: which pain relief will you prescribe her? Now she only has radiotherapy, right? Okay, for the painful bone. What other pain relief would you prescribe her? Anyone? Or morphine? Let's say morphine, depending on the what we call it, WHO pain leader lah, huh? Let's say the pain score is now 3. So what you want to give? Yes, ECN and NSAID. Okay. COX-2, yes. COX-2 is very good for solid tumor or bone pain, and especially proven one is Celebrex lah. Procute particularly like this Celebrex. Okay. Okay, good. She is having increasing pain despite paracetamol and NSAIDs. What is your next choice? Opioid based, yes. Example? Okay, we try to let Nur Asfahan. Yeah, can you say something? Opioid, what opioid you want to
Hi,
use?
doctor. Other choices of opioids we can use is tramal, syrup morphine.
Okay. Mm-hmm.
Then if dihydrocodeine, and if she's not responding, can offer subcutaneous method of morphine.
Okay, okay. So you want to use opioid-based medicine first, such as tramadol, oxycodone, dihydrocodeine. Okay. If not effective, you can go to morphine. Okay.
Yes, doctor.
Okay. You all like to say sub-Q morphine first. Yesterday we had session like in physical session. Many of you want to say, I want to start sub-Q morphine first. Do you think we want to start sub-Q morphine as a first line?
Well, if patient can tolerate orally, we can give oral first, doctor.
Yes. It's in your tutorial, right? I think I have question that if oral route is not, only oral route is not possible, which route you want to use, right? Subcutaneous. Okay, so subcutaneous is actually the second one. Okay, we can give syrup morphine. Okay, now anyone has experience in starting morphine? Anyone? You've prescribed morphine to any patient before? Anyone? You want to share your experience? Especially those who had practiced in a palliative care unit. Anyone? Because I myself have never been practicing in palliative care unit. In primary care only when I start to use morphine. Okay, looks like no response. Okay, so the next choice is morphine. So to start morphine, because of the stigma of the society, so what are they worried of? Then I got one answer here. Kirtana? Yes, you did in a palliative. I think the principle is the same. Kirtana?
Yes,
Okay.
doctor.
You want to share with us your experience in
But
starting?
directly, I didn't start morphine, but during my PITS posting as a medical officer about in Klang Hospital, we managed a lot of cerebral palsy patients. So this boy was 18, 19-year-old, but he was still under pediatrics at time. So he was during his end stage, the palliative team intervened that time. So they did give subcut morphine actually. But I couldn't remember the doses, but that is to reduce his pain during his last stage actually. Yeah.
Okay. Some more this is not a cancer patient.
Yeah.
Maybe a bit different. Okay. Okay, thanks. So to start morphine, because of the stigma of about the morphine, the opioid-based meds, what are the stigma you all know about? It's in your assignment also. Okay, addiction, yes. What else? Die faster, yes. Why die faster? Hasten death. So what can hasten death? What are the symptoms you may get? Yeah, Aisha. Hypoventilation. What is another word for? Okay, respiratory depression. Okay. So would that happen? Addiction or respiratory depression? Would that happen in a starting opioid or the morphine? Okay. No, very rare. Okay. I will say very unlikely lah. You can say no. Particularly, there's a reason for it. Well titrated is one thing. In using morphine in a terminal patient or cancer patient with proper monitoring, without sedation. I would say add on one thing is without sedation, with proper monitoring, the complication of addiction and respiratory depression is almost unlikely. Okay, in medicine we cannot 100%, but it's almost unlikely. But if patient is sedated, intubated, maybe it's different case. Then it's quite difficult to monitor. And patient is used in acute case, not a chronic pain relief, like only 1 or 2 dose, then must be very careful about the respiratory depression. But in cancer patient, it's very unlikely. Okay, you can answer that way lah. Okay, since there is stigma about this morphine, usually when you start morphine at home of your patient, you better have a family conference lah. I used to have a family conference together with family and the patient. Tell them about the risk of addiction and restricted depression is almost unlikely, provided the patient is having a good monitoring. That's why monitoring is important. So at the same time, you may ask the family member to someone to help you to monitor the dose of morphine. Okay. But having said that, starting morphine may cause some mild complication. What are they? You should inform them also during the conference. Yeah, vomiting and constipation. Okay, sedation may not be lah. Sedation, if the proper monitoring, also unlikely. But very common ones, nausea, vomiting, and constipation. That's why you need to start laxative and antiemetic right from the beginning. Whenever you start morphine, you start prescribed together with antiemetic and laxative. Do not wait until the patient develop symptom, only you prescribe. Patient will be frightened and don't want any more morphine. Okay, lost confidence. Okay, that's important point lah. Okay, dosing of starting morphine for an opioid naive patient, you can start with 2.5 to 5 mg. The common one we start with 5 mg. But if the patient is so thin, cachectic, and also patient is frail, you can start with 2.5. And we use oral syrup morphine. Syrup first, syrup, okay? Easier to ingest. Or sometimes we use immediate release tablets, okay? And we have regular dose and breakthrough dose. Regular dose is we give constantly every day, 4 hourly, okay? And regular dose should be given evenly throughout 24 hours, every 4 hours, and 6 times per day. In between, if any pain, you can give breakthrough dose, okay? Pre-RN basis, okay? The BRN basis doses also same as a regular dose. It's 1/6 over the total dose of day. It's the same. And patient is not controlled, and the pain is not controlled, you can always escalate, increase the dose by 25% or 50%. Okay? Not too high up, slowly increase. Because you worry about their concern, right? The respiratory depression. It's how we control not to let this complication happen. Okay? When the dosing is stable, you can convert to slow release tablet. Okay? Immediate release tablet or syrup first, then you can convert to slow release tablet. Okay? And you can need to review every day. Okay? Breakthrough dose is at least 1/6. Okay? Now I give you an example. I don't have example here. Okay. Let's say we want to start morphine. You can find this example in the guideline of handbook of palliative care. That's a one. So sorry, just a moment. Just lost the. Okay. We start with morphine. Look at the chat box. Regular dose and breakthrough dose. So you give 5 mg for hourly for day 1, let's say. The total dose will be 30 mg, right? mg times 6 equals to 30 mg for day 1. So if day 2, patients still have pain, you can add on, you assess the any breakthrough pain. If patient need extra 3 doses for day 2, meaning that the whole day patient will need 9 doses. So the total dose per day is 45 mg. Day 2, okay? So in day 3, you can give the morphine, syrup morphine, 7.5 mg. Okay, 7.5 mg times 6, okay? 7.5 mg times 6. Okay, day 3, 7.5 mg times 6 is equal to, okay? Let's say in day 4, it's already stable, 45 mg. You can convert to slow release tablet, 20 mg BD lah. It's 40 mg. A bit lower is okay, because you don't have the preparation for 45, 22.5 mg. And day 5, if patient have any pain, you can give 40 mg BD first, plus 7.5 mg syrup PRN. Okay, if any pain, so you keep on escalate or de-escalate depending on the situation. Okay, so it's how you start morphine and monitor. You can do it through phone if home visit patient, or you can do the home visit every day lah. You calculate the total dose per day. Okay. So any question? But if in real life, when you start the morphine, you start one dose one day, 5 mg, 3 doses already. Patient will tell you enough, no pain. Because they're so scared of the side effect. Okay. Chan, any question, Chan?
Doctor, do you mean 20 mg?
Oh yes, it's 20, sorry. 20 mg BD. Okay. Typo. Okay. Day 5, huh? Day 5 is 20 mg. BD, huh? Plus the PRN dose. Okay. Okay. Now, we have this chart. Okay, look at the slide. We have an equal analgesic potency of opioid. Okay. So you can have this chart in your clinic. And we use this column only. The last column, forget about it. Sorry. You did use this column. Okay. So meaning that you want to convert syrup morphine here to any subcut or any other things, the dosage 30 mg equals to 10 mg subcutaneous IM or IV. Okay, This is used in patient which is opioid tolerant. Just now the case is said opioid naive patient, right? Opioid naive is those opioid naive never been started on morphine before or opioid-based medicine before. Then you start with this dose. If patient is opioid tolerance, meaning maybe the patient already started on morphine or tramadol or oxycodone continuously for more than 1 week before starting morphine, syrup morphine, then you need to consider the dose. You may need to increase the dose of the morphine by converting. Let's say patient before that, 1 week ago, continuously on tramadol 300 mg. So your morphine, instead of starting by 0 dose, you need to start 30 mg first. Then only you add on 5 mg, six times per day. Then you have total day one dose will be 60 mg already. Okay, so need higher dose for those opioid tolerance. Okay. Another use of this chart is, let's say patient discharged from HKL, prescribed by the oncologist, the palliative care medicine specialist, oxycodone 20 mg, let's say BD, come to your clinic, but your clinic do not have oxycodone, but you have tramadol. You can give, instead of oxycodone 20 mg BD, you can give tramadol 300 mg BD. The effect is almost the same. I mean, the effect for pain control is almost the same. Actually, I tried it before. It's quite useful for this chart. Okay?
Excuse me, doctor. Can I just ask one question? The
Yes.
tramadol you said as in giving 6 tablets in one go?
Just example only. Yes, if really need so high dose.
Oh, so 6 tablets in one go, but then we give the additional one some other analgesic.
No, meaning that if the patient is charged already on oxycodone,
I see.
let's say it's 20 mg BD, quite high dose, no? So
Yeah.
you want to replace it with tramadol, then you can give very high dose tramadol.
I see. Thank you, sir.
Okay, you just refer to this column. 20 mg oxycodone equal to 300 mg. But usually not high dose lah, not so high dose. But one question to you, what is the higher dose of morphine?
As for clinic kesihatan, so far the highest that was allowed was TDS 50 tramadol 50 mg TDS.
Oh, that one is for opioid based lah.
Yes,
I mean
opioid
morphine.
based, yeah.
Morphine?
Morphine clinic kesihatan, so far our clinic we do not have that.
You don't have lah. Any
Yeah.
idea? How?
Because if at all anything also immediately we send to the hospital, as the hospital is about 10 minutes away. So on oncology, usually there is no patient under our follow-up yet.
Okay. So you are working in KK, right, Saban?
Yeah, I'm in KK. KK setting in Miri.
You know later on, your domiciliary service, you have palliative unit.
Sorry, I have?
The domiciliary, you have
Domiciliary, yes, we have.
Later you have palliative, they are trying to do in
Yeah.
all KK to have this. Then later on, you need to know how to use morphine.
Understand.
Later lah, later. Okay.
Thank you.
FMS, you must know lah.
Oh, boss.
Okay.
If I become FMS, I belanja you first, boss.
Okay, thanks. But you should prepare yourself lah.
Yeah, sure.
Even though MO, you should know also lah.
Yeah, definitely. Thank you.
Okay. Like, actually, morphine has no ceiling dose. Okay, like what Joshua said is correct. Actually, no ceiling dose. And in palliative care unit, actually patient receive 300 mg total dose of morphine per day. And patient can conscious, patient can talk and eat, but receiving every day 300 mg. Still okay. So that's why the pain relief is the main concern for morphine when you use morphine. Also in your tutorial question, right? Okay. So they try up to 300 mg. Also, no respiratory depression, no addiction also. Okay. The highest I know is 300 mg. According to palliative care medicine specialists, they even give higher dose, higher than that. Okay. So actually no ceiling dose lah. But whatever it is, you still need to monitor the patient closely. Okay. That's why you need your pain scale. You need to the escalation. You need to calculate every day. Okay. Okay. Morphine finish. Now we go to case number 6. Angie has progressive back pain and now has weakness and numbness in the right leg. She has difficulty controlling her urinary works. What is the diagnosis? Yes. Anybody else? Spinal cord compression? Man, so tired already. Everyone? Anybody else? Come on, we have few more question only. Yes?
Bleeding.
Hello? Any other question? Yes? Any other answer? Okay, history of trauma. Renu, why you want to ask about history of trauma?
Doctor,
Yes.
possible she had a history of trauma which caused some uh, spine fracture or something, then progressively
Okay.
causing
Okay.
other
That is
more
okay.
injury.
You mean a pathological fracture lah?
Yeah.
Right. Okay. Okay. But that one is you need to assess further. Now we want to ask both slightly diagnosis here. Okay. Kumota, why diabetic neuropathy?
Differential diagnosis, Prof. Because weakness, numbness, and then itu difficulty controlling urinary.
Okay. But now because always you need to look back the scenario, the case. This is a continuation from just now.
Okay.
NG, same person. Okay. Okay, match the spine, yes. So what would you do? What would you do? Refer, okay. Okay, roughly you want to do, if refer what they will do. Okay, neuro, okay. Do MRI, yes. Okay. Urgent MRI, okay. I think this case is in a tutorial, Okay, you want to assess the acute urinary retention. Renu, again, Renu, you want to assess if you have urinary retention, but if you read the question carefully, maybe the wording here, she has difficulty controlling her universe. What does it mean? Renu, are you around?
Yes, sir.
So you read the
She's
question.
unable to withhold her urine, sorry.
Okay. So this will lead to acute
Incontinence.
urine
No need to acute
retention.
retention. Yes.
It's more to incontinence, right? Rather than retention, right? Okay. Malini?
Yes, doctor.
Yes. So you want to give Hyrocort
Mm-hmm.
to reduce
To reduce the cord edema and preserve whatever that we can preserve the neurological function lah, doctor.
Okay. Your direction is correct. But do you think Hyrocort is strong enough?
High dose, doctor.
Mm-hmm. Compared to Hyrocort, which steroid is better? One is better, more stronger actually. But one more question here is always you ask, you want to do MRI first or you want to give DEXA first?
DEXA first, doctor.
Okay. Okay. But if you do DEXA first, how confident are you is spinal cord compression?
Clinical examination, doctor, because preserving the neurological function is more important than, because MRI it will take time.
Okay. Anybody else? Because just now you all have other concern, right? You want to assess the urinary works, you want to assess the any fall trauma before, right? Assess neuro. So if you want to assess all these things, meaning that you might not be very sure whether it's you know what I mean? How very sure you are? Okay, based on history and animation. Okay. Okay. Actually, this question is can be debatable lah. But conclusion from whatever it is, you still need to confirm the diagnosis lah. So usually it's MRI first and DEXA later. Okay. Because medical legal lah, we still want to confirm lah. Okay. So you say you worry about the MRI maybe delay, right? Takes time, right? But do you think this is an emergency? Okay. So if emergency, can you request for urgent MRI? Okay. So the concept is there lah. Still emergency. But if you think back, patient already palliative lah. Why want to do emergency? So you still want to do emergency? Okay, patient is palliative, going to die. So you want to do urgent MRI? Or you want to treat first? Wait for MRI, yes. So you want urgent MRI? Would you request, you write a letter to the radiology department and say, I want MRI urgent. Do you want to do so? Early date MRI. So not so urgent already, eh? Anyone? Yes means not so urgent. Okay. So it's interesting question. Okay, go back to the concept. Imagine if anything you're in doubt, you go back to the basic. There are only 2 or 3 emergency in palliative care. Okay, only 2. One is spinal cord compression. Another one is what? You've gone through before during the tutorial. One is spinal cord compression. Another one is what? Okay, let's say patient have a mediastinal, yes, SVC obstruction. These 2 is what we call emergency in palliative care. So you must treat it as emergency, same as normal patient. Okay. Yes, still you need to request for urgent MRI, early treatment, even though patient is in palliative, because the outcome is different. Okay, the spinal cord compression, the outcome is different. Patient may have another 6 months to go, and patient is bedridden, no more quality of life. Okay, but if patient not bedridden, still can spend her time, the rest 6 months. Okay, SVC is even more important. Because SVC, if you don't treat, patient will die straight. If treat, patient can spend longer time. Okay, what if the mediastinal, like lymphoma or mediastinal tumor, is curable after chemo? So this one must take urgent as normal patient. Okay, that's how we emphasize on emergency in palliative care. Okay, only these 2 lah. The rest nothing much. Remember these 2. Okay. Now we go to resource. A few minutes more lah. We have 15 minutes, right? Maybe you can finish early. Resource is talking about the palliative care service lah. Since it's not so, the awareness is so low. So your doctor must know where to find the service first. Anybody? Okay, we start with hospital. Which hospital has palliative care unit? Any Selayang? Yes. Anybody from Selayang? Anybody work in Selayang Hospital before? Okay, it's okay. Klang Valley, where else? Okay, Chan Hospital Umum Sarawak, you mean Queen Elizabeth?
No, in Sarawak.
Oh, Sarawak, sorry. Sarawak is Kuching mana?
Yeah, Kuching.
Okay. Queen Elizabeth, they have Sabah. Okay. Hospital Malacca already have, right? Pulau Pinang. Oh, now more and more government hospital got this unit. Okay. Yes, Selayang Hospital, still remember, I think Dr. Richard Law is there, the author of the Handbook of Palliative Care Medicine. Okay, I think it's there. Okay. Pulau Pinang, yes. HSA also have. I thought HSI is the cancer center. Young from JB or oncology center, not palliative. Okay. Okay. So since like the service is quite widely available in Malaysia. And you know, of course, hospice, right? Hospice Malaysia, Kaseh, Klang Valley region. Okay. Even private hospital, I think Prince Court got uh, palliative care unit also, Prince Court. Okay. Then how about KK? Any KK clinical setting has this palliative care service? Any one of you, your KK? Do you have palliative care service in your KK? Or don't have? Okay. I think some of the KK already have palliative care unit service. And for your information, okay, for your information, if you become an FMS or family physician, you can start specialize in palliative care. Okay? Few of them already become palliative care medicine specialists already. Okay? Because we are lacking of this service, even though you are not palliative care medicine specialist or FMS, even your MO, I encourage you to provide more service like in palliative care. Okay? And get to know some knowledge on palliative care, then you can do the service. Okay? It's very lacking and you need your support also. Even GPs, you can do home visit also. If you have trouble getting the morphine, can always ask from hospital. Most of them are quite helpful, I think. Okay. Okay, now, any questions so far? Before we go to the assessment, let's wait. Assessment is some MCQ on what you have learned. Okay. Simple one. You go. See whether you learn something from this session, this workshop. Number one, okay, Mala, 30-year-old lady has routine medical checkup. The blood test result as follow. Full blood count. Okay, Finish reading. Okay, peripheral blood flow. Answer. Okay, very good. You learn something. No other answer. I take it as 100%. Now, number two, you read yourself. Read carefully. Okay, I can see different answer. Kartini? Kartini?
Yes, doctor.
Why E?
Oh, I thought she's in severe pain, so oral will take some time. So,
Oh, okay.
but I think eventually oral morphine.
Mm-hmm.
Mm-hmm.
Okay, so actually, yeah, I know your query. To decide on syrup morphine and iron morphine, it's not because of the intensity of the pain. Okay, because the intensity of pain, like pain score, let's say is 7 or 8. So it only decide whether you start on NSAID opioid base or you start on morphine. If you decide on that only, the route of administration of the morphine or opioid medicine is not based on the pain score. Okay, it's based on which one is easier. So oral morphine is always easier and you can cause less pain to the patient. Okay, unless oral route is not possible, then you need to think of second route. So what is that? Oral route not possible? Sure, you can give what? And all these are going to be palliative patient, end stage already, terminal. The principle is to keep the patient as comfortable as possible. So you give oral not possible, you give subcutaneous, okay? If patient is very thin, oral route and subcutaneous route is not possible, what you want to give? Anything? Okay, just spend some time before we go off. Continue? Ask you again. If oral and subcutaneous route is not possible, what do you want to give?
Patch cannot. No.
Yes, patch. Okay. You go to something less invasive.
Okay.
IM is always not in the consideration. Inject painful, okay? Patient terminal already don't give so much pain. No?
Okay, doctor. Thank you.
So the answer here is oral morphine solution or immediate release, not slow release. Slow release is on a day 4 or 5, right? We discussed just now, right? So we start with oral morphine first. Oral solution morphine, okay? Solution is a syrup or elixir. Okay. Last question. Okay. No other different opinion, So we take it as 100%. Okay, good. That's all for today. Do not forget to fill in the evaluation form. So your feedback is helpful for us to improve the system, the teaching system. Any one last burning question? Okay. I want to thank you all also for so interactive. Otherwise, I'll be talking to myself very scary. Okay. I think your group is quite interactive, quite good. So I hope you learn a lot from this session. Okay. Okay, we call it a day. Thank you very much for your attention.
Thank you, doctor.
Have a nice day. Okay.